Assalamu alaikum. Uh, the case that we are discussing today is a young lady around 30 to 35 years of age and who underwent cesarean section. And during the process, she had an injury to the right ureter, and she presented to us with urinary incontinence. And upon investigations, it was found that she's having left ureterovaginal fistula with a left dilated ureter as well as the kidney. So we decided to go for laparoscopic repair, which is the laparoscopic ureteric reimplantation. So the process began with putting in and placing the ports for the camera and the working and then the steps are being followed here, which are on the left side specifically for ureteric reimplantation, the mobilization of the colon, dissecting and identifying the ureter at an area which is virgin, that is the iliac bifurcation. So for that we have to mobilize the sigmoid colon and identify the common iliac vessels, the common iliac bifurcation, and then identifying the ureter, which is not very difficult to identify because it is already dilated so much that it comes to our way by itself. So here you can see the external iliac vessel, external iliac artery, and then dissecting proximally we will go to the bifurcation of the common iliac artery into external and internal arteries, and the ureter will be crossing this bifurcation, so it will become easy. But essence is to keep the field as much blood free as possible, because discoloration of all the things into red will make it difficult to identify the ureter, and then dissection will also be a little difficult. The other important thing is that while mobilizing the ureter, one must be aware that the vascularity has to be maintained, because the ureter gets its blood supply from the lateral aspect during its course in the distal portion. This is the internal iliac artery. So it is always good to leave some tissue around the ureter, which is also called the periureteral sheath. Small blood vessels run longitudinally within the periureteral sheath, and thus maintaining the blood supply. For any reconstructive procedure, vascularity is a must, because if the vascularity is compromised, reconstruction is most likely to get failed. So here we dissected the ureter enough now, and then making a window. And in this window I usually place a silk, and then I create a small 2 millimeter hole in the peritoneal cavity, which acts like a small 2 millimeter port, and then I bring this loop outside and hold it with an artery forceps outside the abdomen. So this serves me with a good retraction. So now the formal mobilization of the distal portion of the ureter has begun. Now we can clearly see the course of the ureter. We'll try to mobilize it, leaving some tissue near the ureter. Mind you, here the layer of the peritoneum, which is covering the surface of the medial aspect and anterior aspect of the ureter, will be left alone. and that too because this layer will also harbor some longitudinal small vessels which will be helpful in the vascularity. So now we mobilize this, detach it from the extra tissue as well as the fibrosis. Mobilization is extremely important because the anastomosis between the ureter and the bladder has to be totally without any tension. A slight bit of tension will lead to ischemia and of course again stenosis and stricturing of the uretrovesical anastomosis. So keeping in view the vascularity, we have to mobilize the ureter, and some blunt dissection will also be performed and small vessels will bleed. We don't mind those small vessels because if we coagulate them, this will also lead to ischemia of the ureter. Care must be taken for the internal iliac vein because usually this area where there is ligation, there is leakage of urine, there is a lot of fibrosis, so at times the vein is strictly adhering and strongly adhering to this part of the ureter. So immobilization of the ureter up to the point where there is fibrosis is important. Number two, mobilization where we can see that ureter can be anastomosed to the bladder without any tension is also an important thing to keep in mind. Complete mobilization up to the level of ligation or injury is not necessary. Now comes the mobilization of the bladder. As in laparoscopy, we need to bring down the bladder and apply 1 or 2 stitches to the extravesical tissue on the Psoas muscle, so that during the repair the bladder does not go away from us and relatively is static, so that a good repair and anastomosis can be performed. Mobilization should be done as close to the anterior abdominal wall as possible, because if you do the dissection close to the bladder, there is a chance that the bladder will be open. Nothing bad will happen if the bladder is open. One can repair it again, but and in majority of the cases it can heal by itself. However, this will add to the morbidity. So we mobilize the bladder until we identify the pubic symphysis, and care must. Oh yes, this is the pubic symphysis. This one. Okay. And care must also be taken not to injure the inferior epigastric vessels, although the obliterated umbilical arteries come into way, and those can be clipped or carefully coagulated, because it is known that they are thought to be obliterated arteries. However, if they get injured and open, they can bleed significantly at times. So care must be taken. This is the vessel that we so we are checking here whether we can easily come. So this fallopian tube and ovarian complex is preventing the bladder from being mobilized up till the Psoas muscle. So we take down the peritoneal covering laterally. This is the round ligament, the round ligament of the uterus. So all this complex will be mobilized from the lateral pelvic wall, so it will come medially and give us some space. And this space will then be used to retract and pull the bladder, fix it to the psoas muscle, the fascia of the psoas muscle. Care must be taken not to injure the external iliac arteries. This last bit of fibrotic tissue that is being coagulated and cut. Now you can see that it can be beautifully lifted up. And pulling the bladder towards the psoas muscle will point us to the limiting factor, which is effective against the mobilization. So that limiting factor is identified and then mobilized. Here you can see that these fibers are restricting the mobilization of the bladder, and it cannot reach up to the psoas muscle. So these attachments are also mobilized slowly and gradually, keeping in view the various structures. So this round ligament is coming into our way, so we are clipping it, and then we will cut it between the clips so that it gives way to the bladder. A little bit of fibrotic tissue again coming into our way, that is being taken down as well. So here you can see that obliterated artery, the umbilical artery, that is properly coagulated at multiple sites with the vessel sealer and then cut. So slowly and gradually taking down the attachments of the bladder and the perivesical area, the bladder will be mobilized. Now we decided to cut the ureter at the site of obstruction. Here we are not using any diathermy or energy source, and a pure cut is made with the scissors. It is okay if it is bleeding a little bit after cutting it, if it is bleeding, so we can coagulate that portion. It is not really important to clamp the distal stump of the ureter because it is already stenosed and obstructed. A little bit of spatulation on the posterior aspect of the ureter is made so that the anastomosis is wide. Now, a Vicryl 2-0 suture is taken, and this suture will fix the extravesical tissue with the psoas muscle, the fascia of the psoas muscle. Care must be taken not to take the bladder itself. The bladder wall, if taken, will give tension, and too much stretching of the bladder wall and detrusor will lead to voiding dysfunctions. So this muscular fascia is connected with the extravesical tissue along with the peritoneal layer. Surgeon's knot is applied. This can be done with the Vicryl 2-0. So this mobilization of bladder is of utmost importance in ureteric reimplantation laparoscopically. This is not done routinely in open procedure, but in laparoscopy, fixation of the bladder is really important. The bladder is empty, not completely filled. So when it is filled, it will become more near to the anastomotic side. Usually one suture is enough. However, for additional support to the single stitch, another stitch can be taken. Not really a deep stitch is required, only taking just the fascia or the epimysium of the muscle is enough. As I also mentioned in the previous video in VVF repair, it is important to take out the needle under vision and cut all those extra sutures, because the sutures will be coming into our way again and again, confusing us. So now we decide where to place our ureter and its anastomosis. So there is a sling applied. If we remove this sling from the ureter, this will make anastomosis easier without tension. The ureter is healthy, its distal end is vascular, the peritoneum is attached on the ureter. That's why it becomes a little big. However, we should not be removing this peritoneum from the ureter, as it will devascularize. So this is the proposed site on the anterior surface. However, in open surgery, the posterior surface is used, and the dome is used for uretrovesical anastomosis. But in laparoscopy, we use the anterior surface of the bladder. Careful diathermy with the scissor monopolar is used to dissect out the perivesical tissue, and then we'll make a small tunnel. It is not really important to make a submucosal tunnel in adults, and that too especially in the ladies, because females usually have a low pressure bladders, and the reflux does not matter in adults, number 2. And number 3, since the patient is here for obstruction and not a reflux, so the main aim of this surgery is to remove the obstruction rather than to prevent reflux. However, we will consider a small submucosal tunnel if that can help. An additional stitch is taken to fix the ureter to the bladder, so that the anastomosis becomes easy. So we plan on a site here to apply a stitch to the ureteric wall. So this will add to additional safety, so that when the bladder is empty, there will be no tension on the anastomotic side. It is important to mention here that this stitch must not be deep enough, only a serosal layer. It should not be transluminal, because you may catch the other wall of the ureter, and this will lead to obstruction again. However, the stitch is not necessary, but it does help in fixing the ureter really. And care must be taken not to take stitch in an area which will make the ureter stretch. So the ureter be placed at an easier location. Remember, we have and this stitch is I have taken this with 40 vitral. Now the bladder is full. Remember, it should not be overfilled, because this will lead to, if it is overfilled, a slight rent in the bladder wall will make the mucosa vulnerable to open. So it should not be completely empty, and it should not be completely filled. It should be half filled, so that the structures can be identified, the muscle can be easily dissected from the mucosa. This is detrusor muscle, and the blue color of the mucosa is now visible. Small vessels being taken care of. So the scissor is being used with monopolar diathermy for separating the mucosa from the detrusor wall in order to promote the formation of a submucosal tunnel. This side of mobilization of the mucosa is easy, but the other side is a little difficult. For that, we have to grab the mucosa with the forceps and then do the dissection, but it really is difficult. It's not as easy as this wall is. Some more mobilization and of the mucosa of the detrusor. Now comes the other side. Our forceps is traumatic. A little bit of washing and then using suction for the dissection. So our forceps is traumatic, and it may make hole in the mucosa, but I think the tunneling is enough, although the length may not be enough, but it is wide enough. So even if the mucosa is open, it doesn't matter, as we are going to open it anyways. So enough of mobilization is now there. The same area is used for cutting where the bladder mucosa was opened traumatically. So the ureter will be anastomosed to the tip of the mobilized area. We take 40 vitral. Different sutures can be used. 30 vitral can be used. 40 vitral can be used. Some people use even PDS, and some people use V-lock sutures. At this point, the step is important to take the exact corner and not catch the opposite wall. The first stitch is really very important. Not only first stitch, but first few stitches. So there are different methods of anastomosing this ureter to the bladder. It can be done in interrupted suture fashion, and it can be done in continuous fashion. So outside in from the ureter and from inside out into the bladder. And now making loop, taking a surgeon's knot. The first knot must always be a surgeon's knot, so that it does not slip, because leakage again may lead to stenosis. And vitral, 4 knots are enough. Vitral usually swells up, and its knots can be undone. So we have decided to do a continuous suture anastomosis. So we take the needle to the adult side and we cut this tail in, because if we don't cut it, it will come again and again into our way. So reverse sutures are taken from the wall away. This is the mucosa. The first 1 or 2 stitches are extremely important to prevent any leakage. So once this wall is done, then we will place a degestant, and then we will perform continuous suturing of the other side. Care must be taken not to close the lumen, and sutures should be taken under vision. Yes, of course, first few stitches are difficult because the lumen of the ureter is small. And we have to tighten the continuous suture. Now again, outside into the bladder mucosa. At this point, an assistant can do the suction and clean the field so that both the edges of the bladder wall are visible. Four interrupted sutures can also be taken, one at the apex, one at the corner, and 2 on the left and lateral wall. But continuous suturing can also have a watertight effect. Number 1. Number 2, repeated knotting is prevented. So, inside out, and the loop is outside, and we will just bring it through the loop and tighten it. It is important to take this needle away because we will take another suture and these needle may be confusing. Here you can see that needle has come to our field again. So this corner stitch is important. Careful not to take the opposite wall. Now it is clear. Before placing the stent, we just take this stitch this cornering for suture is extremely important. This is a nice place to take the stitch. Nicely done. It is important that doing suturing laparoscopically, the suture must not be more than 20 centimeter, because then it is extremely difficult to handle it laparoscopically. Number one, here you can see that the tail is also, so we cut it and just bring it out. So if there is a long tail, it also hampers. So we placed that same 2 millimeter needle port, and through that needle port we placed first the guide wire into the ureter. It is extremely difficult to stent this grossly dilated tortuous ureter. It is okay if the stent does not reach the pelvic ileal system. We just need to bridge this anastomosis. However, the port is placed in line with the ureter. So luckily it has reached the pelvic ileal system, and now the distal end of this stent is placed into the bladder under vision. Care must be taken not to take the stent in the suture, because subsequent removal will not be possible. It will be a disaster. In the meanwhile, once again, the assistant can irrigate and do the suction to clean the area. The suturing must be completed under vision, not to take the stent in the stitch. The suture must be tightened to ensure watertightness. It is important not to grab the ureter itself with the traumatic forceps. We are holding the ureter by the peri-ureteral tissue, because trauma can also lead to ischemia and again fibrosis. So this is the last stitch, it's the corner. It's important not to take the stent again. It must be under vision. So we are at the level of the suture from the opposite wall. Now last stitch is taken. Then we will knot this suture to the opposite wall suture, and the anastomosis will be complete. And after that, one or two stitches can be taken in the perivesical tissue or the detrusor muscle. Take the needle out under vision. So the ureter is then buried in the submucosal tunnel. Use the anti-reflux surgery. As I mentioned earlier in the procedure, it is not usually needed in the adults, especially in the females who have low pressure bladders. And as the case is here for obstruction, the indication of surgery is obstruction, not reflux. So it is not important to prevent reflux, but it's important to prevent restenosis. So after this suture, some irrigation and suction is performed. And the area is cleaned, and then a drain is placed transperitoneally in one of the port sites, and then the procedure will be completed. Thank you for watching the procedure.